we're on.
Okay, Susan, take it away.
Hi, everybody, and welcome to Biotensegrity party number 36, an osteopathic perspective. Today we have our special guest, Ed Stiles. Ed, can you give everybody a wave? And Ed is in Lexington, Kentucky. Do I have it right?
Correct.
Wonderful. And I'm in Washington, D.C., the birthplace of Biotensegrity, where the Needle Tower once stood and we hope stands again one day. Are you listening, Smithsonian Institution? And I'm here with my co-hosts, Chris Clancy, who's in Deep Cove outside of Vancouver.
Hi,
Hey,
Susan.
and Graham Scarr, who's in Nottingham. Hey, Graham.
Hello, Susan. Hello, everybody.
And our wonderful, really, I keep saying assistants, they're amazing teachers of Biotensegrity in their own right, each one of them. And they help us every week, and they're just always co-hosts with us. Rachel Tudor, Rachel's in Tumwater in Washington State, right, Rachel?
Great. Hi, everyone, and thank you, Susan.
And Lisa Babiak's in St. Albert.
Yes. Hi, everybody.
Way up in Canada. I hope to get there someday. And Mariana Barreto is in Mississauga, outside of Toronto. How did I do?
Yes, almost. Mrs. Saga. Welcome, everyone.
Gosh.
Not quite.
Well, I'm hoping I put Mississauga on the map by the way I keep mispronouncing it. People will say, what's her problem? And we also have in McLean, Virginia, right outside of Washington, D.C., Dr. Stephen M. Levin.
Hi, all.
Yeah, hi, Steve. Steve originated the Biotensegrity concept. So we have the home of Biotensegrity right there at Steve's house, right, Steve?
Yes, you do.
And there are a lot of wonderful other special people out there today. Can I give a special hello to George Roth? Hi, George.
Hi, George. Hi, George.
Hi, this is my first encounter with this group. It's delightful to see everyone.
And George, are you in Toronto?
Yeah, I'm in Toronto, yeah.
Oh, great. All right, so I'm going to hand it over to Ed for the toast, and then we'll hear about sponsors, and then we'll get on with the main program. Ed, over to you.
Okay. Can
Wait,
you hear me?
Ed, hold on. This isn't the presentation part.
Yeah, we're
You're just
doing
giving the toast right now, and we'll get to the presentation in a few minutes. Thank
Okay.
you.
So I want to toast to Steve
Ah,
for all the years of dedicated work and challenging thought and exploring and trying to tie this into the practice of medicine. I also want to toast my mentors who sent me down some amazing pathways. And I want to also toast patients who taught me so much over the years.
Wonderful.
Good. Thank you.
cheers.
Thank you. Cheers.
Cheers.
L'chaim. All right. Thank you, Ed. I'm going to go over to you, Graham, for the sponsors for today.
Okay, thanks, Susan. Now, the Biotensegrity Party is an all-volunteer production of the Stephen M. Levin Biotensegrity Archive, and made possible in part through the generous support of our wonderful sponsors, starting with Handspring Publishing in East Lothian, Scotland, have a wide range of authors and books suitable for movement and manual therapy professionals. They're offering a discount coupon to all those on the Biotensegrity Archive mailing list and our Zoom participants. Handspring also produce a newsletter entitled Springboard, which you can join from their website, handspringpublishing.com, and which provides details of their series Move to Learn, hosted by Elizabeth Larkham. We're also supported by Chris Clancy's educational organisation, Embodied Biotensegrity, based in Vancouver, British Columbia, and which provides an excellent resource for those of you looking to learn more about Biotensegrity. The Biotensegrity Party is also sponsored by Artifact Pro of Madrid, Spain, where you can find wonderfully constructed anatomical tensegrity models. And they're offering a discount coupon to all of those on our Zoom participants, which you can be part of by signing into the Biotensegrity Archive website and sign up for our weekly newsletter to explain what's going on in tea parties coming up, and also get these discounts. We're also supported by the fasciahub.com, which starts with a full day of talks on the fascial pelvis tomorrow, the 28th of November. So you've got a few hours to register for that, the fasciahub.com. And finally, Integrated Biotensegrity are producing a Q&A session on the 10th and 12th of December, which follows their one-day course at the beginning of November, with Lisa Babiak, Paul Thornley, and Rachel Tudor. So I think these are timed to fit in with the different time zones in the world. So check out them on the 12th and 10th of December. And I think that's our sponsors. Back to you, Susan.
Fabulous, Graham. And there's it's amazing how many wonderful resources are out there. Neil Galloway and John Sharkey are both going to be part of the Fascia Hub event on the pelvis tomorrow. Do you want to just give a wave, John and Neil? Say hi. You can unmute and say hello real quick if you want.
Hi, and hello to Dr. Stiles. Really looking forward to this. Fantastic.
John, good to see you again.
Good to see you.
And Neil, are you here as well? I think you might be. Anyway.
Well, can I also drop in there and say that Anna Crowell from last week, talking about the pelvis, will also be talking at the Fascia Hub tomorrow as well.
Oh, that's wonderful. That's great news. And I have to say, we have an unprecedented number of views on the show for last week. So I am delighted that we have a small part in getting this really important information about women's health out to the world. It's a delightful thing to be a part of. I'm going to turn it over to Steve, and he's gonna, Chris, did you have something you wanted to say?
Yeah, I would just like to say that at this point, we like to ask the audience to please turn off your video recording. What that does is makes it better viewing for our YouTube audience.
Yes, thank you.
And I'm going to introduce my friend Ed Stiles, who I actually haven't seen for many years, but we go back some, I think, to the 1980s. Yep. When we worked together at University of Michigan State University College of Osteopathic Medicine, and also at the North American Association of Manual Medicine, which no longer exists. And I was sort of a ringer. I was introduced into, I'm an MD physician, introduced into the osteopathic community. And I found out that the osteopathic community not only had all the MD, the allopathic medicine, but on top of that had a whole new concept, at least new for me, of osteopathic medicine that sort of overrode the whole thing. And in the United States, the osteopaths are the equivalent of allopathic physician, MD, but actually they're much more than the allopathic. They're specialized at another level. Ed and I taught together, but he is one of the finest teachers I've ever seen or met. And right now he's professor of osteopathic medicine at Pikeville College of Osteopathic Medicine, I believe. He's been there for years. He started out at, I think his training was at Kirksville. Then he was in Waterloo, Maine. And then so I forget where else. He's been bouncing around different places, but ended up in Pikesville and has been there since since it opened in the late 1990s, I believe. So he's been there and a mainstay of the community. He has all sorts of awards through the osteopathic community and is one of the finest teachers I've ever met, as I said. And I'm turning it over to Ed.
And I'm going to interrupt. Sorry. I meant to say, we're so excited to have Ed here, and he's got a lot to present. I asked him to present on his understanding, his work, and his research. So this is going to be, I'm warning you now, a longer one than usual. And we're going to give Ed free rein. So strap in, pour yourself another cup of tea, and Ed, over to you. Thank you, Steve.
So I do this now.
Mm-hmm. And then the PowerPoint. And then-
Ed's got his granddaughter Madison there as a secret weapon. She's actually a genius bar person. Hi, Madison.
Hi.
How do I get this out of here?
Okay, so watch this. So you're just gonna go right here,
Okay.
and that's as small as it has to
Okay.
be for right now.
All righty. Can everybody hear me?
Yes.
Okay. So Biotensegrity from an osteopathic, and I'm looking at it from a primary care perspective, because the last 15 years, Steve said 20 years ago, 22 years ago, I was one of 5 that started a new osteopathic school in Kentucky. And the last 15 years, I've been working with residents and training residents that are osteopathic graduates who are doing primary care, but want to learn how to integrate osteopathic care into a family practice easily and rapidly. So that has changed my perspective. So that's where we're going to be coming from today, of how I've integrated Biotensegrity into that. Now, I'm having trouble. Let's see. Okay. So let me get, Phil Greenman was a great friend of mine, and he used to say to me, and he did the last time we talked before he died, he said, Stiles, you have to remember that you were the only one in the history of the osteopathic profession that was ever mentored for a number of years by George Laughlin, who was one of Still's grandsons, Fred Mitchell Sr., who developed muscle energy, and Perrin Wilson, who was an internationally recognized DO and very prominent in the United States in the profession during the 40s, 50s, and 60s. And so Phil said to me, therefore, you got a totally different, unique perspective of osteopathy, and that's where I'm coming from. The other thing is Greenman had 2 quotes that are appropriate for today. One was, he said, what makes a DO different is not OMT, but how they think or problem solve. So we're going to be spending a lot of time doing that. And the other was, the expert's the one that does the basics the best. So we're going to be spending a lot of time on basic principles and then how you can apply those to Biotensegrity. I recently in Europe found the phrase Mesokinetic System, and I like that better as a descriptive term for the musculoskeletal system, because as we know, the musculoskeletal system derives from the mesodermal layer of the embryo, but it has to do with motion. So I really think that mesokinetic is a more descriptive term of the musculoskeletal system than the musculoskeletal system terminology. Now, for the osteopathic profession, any mechanical dysfunction in that system, we see it as restriction of range of motion, and not something out of place that has to be put back in place, but to reestablish normal range of motion. And the term we use is somatic dysfunction, which is in the coding books. And if you look at any of the old osteopathic literature, the synonymous word for that would be osteopathic lesion. Now, here's a Tensegrity model that we've all seen pictures of. And remember, there are 2 basic components of it: the compression struts, or the rods, which are non-touching, and a continuous tension system that interlinks that whole system. And as you can see, that wiring system that interconnects all of those rods that are suspended in that system. So let's look at it more from the compression strut side, or the bony side. And this is the one that's on the mall. And tensegrity structures are very lightweight, very lighter than anyone ever would anticipate. They're also much stronger than anybody would ever predict. They have multi or omnidirectional movement potential, and the whole system adapts to stressors. And this is on the mall in Washington. And one time I walked up to it and hit one of those rods going to the ground, and the whole system adapted and adjusted. Then I walked up and hit one of the wires, and the whole system adapted and adjusted again. I thought, wow, that whole system then is constantly integrating and interrelating. And those systems tend to protect the weakest link in that system. And for me, the weakest link in the musculoskeletal system or mesokinetic system is what I call the area of greatest restriction or the most dysfunctional area. So that whole system then is trying to protect that. And so that's why I want to find that area and start my treatment in the area that's most dysfunctional. These systems defy gravity. And whenever I teach that to students, their eyes roll back and you can just see them think, Stiles is crazy. He says you can defy gravity. But one time when I was in Washington, and there's signs all over the place there, do not touch. And I looked around, there was nobody around, and I walked over and grabbed the rod, one of the rods that went from the ground up, and reached up to get it, and held a hold of it and lifted my feet off the ground. And the whole system came down a couple of inches. Then it started to vibrate like everything. Then it stopped vibrating because the pre-stress then was all adapted in. And then it lifted me right up off the ground. And I thought, wow, these systems do defy gravity. And the clinical application of that answered a question I never could answer in practice. Many times after I effectively treated somebody with manipulation, they would get up and say, I feel weird. And you don't like to hear that when you've just treated somebody. So what do you mean you feel weird? They say, I feel taller and I feel lighter. Well, see, what you've done is you've reactivated the tensegrity phenomenon on that patient. Now, after learning about tensegrity, I could explain that. The other thing that's interesting, if you take non-metallic materials and organize them into a tensegrity array, they will conduct electrical current. And all of us that do manual work have had times when we're doing something that feels like there's a rush of energy under your hands. Well, that's kind of hard to explain. But with biotensegrity, it's easy to explain. Let's see. I thought we're also wired to keep our eyes level, our weight evenly distributed in all four quadrants. So say if somebody has a knee injury and it affects, say, the right fibula head, then that can affect the biceps and the tensor fasciae lata. That can affect pelvic mechanics. Pelvic mechanics then can affect the contralateral lats, and the patient can present with shoulder pain. Well, if you don't understand that nonlinear patterning that can occur in the body, and if you just try to go treat that shoulder, you're not going to get a good outcome. And many times a student or a patient will say, I've had 3 or 4 people treat my shoulder, it hasn't helped a bit. And then you treat the fibula head and they say, that shoulder feels better already. How could that be? Well, it's because it's a nonlinear biotensegrity system. These systems also conduct vibratory information. So there's all sorts of information going on in the body that we don't traditionally talk about in neurophysiology or neurology. I can't get this to advance the way I'm used to. So wouldn't it make sense then, in this very flexible, dynamic, adaptive system, to find the area that's most dysfunctional and start treating there, because a lot of the pain in the system is where the body can't adapt to that area. And if you go try to treat the painful areas, then you're just really going down a rabbit hole. Now we're beginning to find out that there's curved tensegrity, and we'll talk more about that in a minute. But the rods are curved, and when they're stressed, those systems tend to expand, whereas the straight rod systems, they tend to pull in to strengthen. Now, let me go back one. But look at the Statue of Liberty. It's a tensegrity system. And I've read that arm up in the air with a torch, that depending on which way the wind is blowing, that can move 18 inches in all sorts of different directions. So that is really a tensegrity system. Now, let's look at for the compression struts. If they're straight, they tend to pull in. Well, look at that slide in the picture in the lower right quadrant. If you take a bunch of vertebrae and you attach little bungee cords to the transverse processes bilaterally and to the spinous process, the disc space opens right up. Now, isn't that interesting? So that if the soft tissues and the ligaments and the muscles around the joints, if they're properly functioning and healthy, then what they're going to have, you can get this biotensegrity effect of taking pressure off the disc. This explains why we can see a patient come in with an MRI that shows very little disc space, and they've got low back pain and sciatica, and they say the surgeon says, I need surgery. And I say, let me check and see, let me examine you and find out there's mechanical dysfunction in that lumbar area or sacrum or innominate and treat that. And many times the patient becomes pain-free. Well, did that open up that space and take some of the pressure off that disc? And I think that's what happened. The other thing is where the straight rods, they pull in when they're stressed. Wouldn't that make sense with the legs? Because if the legs are trying to support this heavy body weight and you stress them and the tensegrity pulls them in, then it's going to make those legs stronger than they would be otherwise. Also, with the arms, and that would enable you to be able to lift more with your arms, push up more with your arms and things. And so it's a beautiful design in that it's lightweight, but gives a lot of strength. And seeing if it wasn't such a lightweight system, our bones would have to be a lot bigger than they are. Then the curved tensegrity, those systems tend to expand when you stress them. So that would be appropriate for the pelvis and the rib cage. And how many times do you treat a specific dysfunction in the rib cage or the thoracic area, and it feels like the rib cage just expands out? Well, it's because you've activated the curved tensegrity phenomenon there. That also is appropriate with the cranium. And many times you find a small sutural problem and you treat that and you get a tremendous cranial response. And I'll show you some data supporting that at the end. And I think also the hands and feet are curved tensegrity things. So we've got two different types of tensegrity going on in the body, which are very appropriate for the needs. So function and structure are interrelated. Now, I look at the pelvis a little differently because I've gone through a period where in 1961, when I was a DO student, if you said if you wanted to be considered a quack, you said you were going to be a DO and you believed there was movement in the sacroiliac joint. And everybody would laugh at you because they said there's no movement in the sacroiliac joint. But in the first tutorial with Mitchell, he put this slide up showing how with a coronal section of the pelvis, that the sacrum is really suspended from the innominate by the posterior sacroiliac ligaments. And so it's not jammed in between the two bones, it's suspended from those bones. Well, that gives you a lot more motion potential. Then remember, Mitchell described three transverse axes. So the superior transverse axis, which would be the cranial sacral axis, the middle transverse axis, which is the one that the sacrum flexes and extends around, and the inferior transverse axis is the axis that the innominates rotate on. And so they're two totally different axes in terms of sacroiliac and iliosacral mechanical function. But Mitchell also described two transverse axes where they're named from the high side. So it will go from the superior transverse axis on one side to the inferior on the other side. And that would allow the sacrum to go into torsion patterns. But I also think there's an AP axis that allows the middle to rock forward and back, and that enables us to have a smooth gait pattern. And we may get a chance to talk about that a little later. And Mitchell also always stressed that wherever two axes cross, that gives you even more motion potential. Well, think about what those concepts could say and teach us about the pelvis then. So here we see the sacrum suspended from the innominates, and there always appears to be a little gap in any picture I've ever seen of the sacroiliac joint. And I think that what would explain that is look at this tensegrity model. We got these two rods that are parallel with each other. They're not touching other. They're not being, they're just being supported by the wiring system or the ligaments. And does that help to disengage that the sacroiliac joint a little bit and allow movement to occur? The other thing that's important is each sacroiliac joint is unique. They're different from side to side, and you need to take that into context when you treat people. Also, I've read descriptions of saying that the cartilage in the sacroiliac joint may have a light roughness, almost like sandpaper, so that when a sacrum keeps going through a movement, it doesn't wear a groove, that there's a little fractal movement and variation of the movement in there each time that protects the cartilage. Then we have these dense sacroiliac joints then to keep those two surfaces, the sacrum and the innominate, disengaged so that then the sacrum can move around those various axes. So I think that's what's the mechanism of keeping that apart. So this enables complex sacroiliac movements. And as some have said, it's a floating compression system. So think about, we've got a floating compression system with a sacrum with 6 axes. And therefore, the number of positions that the sacrum can get in is a quantum number. And the other thing is, if you look at the superior transverse axis on the lateral sacral picture and the inferior one, they're also on an oblique axis. So in that pelvis, we have two oblique axes, one in the coronal plane and one in the AP plane. So the Mitchell model then enabled us to understand how you can get complex sacroiliac movements, how the sacrum then could get in a quantum number of different positions. And therefore, that could also set it up for non-remarkable injuries causing some sacroiliac dysfunction. And so when I'm treating the pelvis, then I want to diagnose any specific innominate, sacral innominate dysfunctions and treat those uniquely according to the diagnosis. And they can either be treated directly or indirectly, but we'll talk later about how they can play a role in pelvic dysfunctions in patients with pelvic pain, et cetera. So now let's look at more from the biotensegrity thing from the myofascial side. And some of the fascial truths are, it's a body-wide continuous system. And what I've been doing is reviewing some of the post-fascial conference reports and finding some of the latest data. And it's fascinating to see what's being said. So it's a body-wide continuous system. The Latin root is bundle, bandage, strap, unifier, binds together. Well, that does a good job of describing it. Then the fascial and others, it permeates the total body, human body. It has a multi-layered matrix. It interpenetrates. It surrounds all organs, muscles, bones, nerves, and arteries. So I hope I'm painting a mental picture of how you've got this diffuse system throughout the body that is interconnecting all regions of the body. And Ingber says that the isolated rods represent the 206 bones of the body, and the continuous wiring system represents the myofascial system of the body. And Fleming's called that a floating compression. And the first time I heard that term floating compression, I thought, that's what it feels like when I palpate a functional pelvis, that the sacrum is suspended in a body-wide sea of continuous tension. And so it's a body-wide able to transfer forces throughout the body and to report sensory information throughout the body. Now, there are three types of receptors in the fascia to monitor movement, tension, and pain. So again, here's a feedback mechanism that gives information to the body to adjust, to adapt, to keep our eyes level, to keep the weight evenly distributed in all four quadrants. Also, fascia, we can go from the macro to the micro to the cellular. And this is what Ingber has contributed tremendously. And the picture in the lower right quadrant of a cell, that's out of Robbins' pathology book. And the horizontal lines represent what he calls the extracellular matrix. We would call it fascia. The four things sticking up are integrins, and they integrate with the fascia, but then go through the cell wall, then connect with the cytoskeleton, that connects with the membrane around the nucleus, goes right inside the nucleus, and therefore connects the whole body with the microscopic level. And what Ingber's shown is if you take one of those integrins and turn it 90 degrees, you change the biochemical and genetic expression of that cell or those tissues. If you then take that same integrin and turn it 180 degrees in the other direction, you get a totally different biochemical and genetic expression. So here was the thing that Still was looking for, where he was saying mechanical forces can play a role in visceral problems. Well, here Ingber is showing how that can actually take place and has that all down now. Also, fibroblasts can turn into myofibroblasts, which enable the fascial system to have contractibility again. So that adds a whole new aspect to the fascial system. And also, you think about all this afferent input that's coming in from all these issues we've talked about. And if you do a cross-section of the cord, remember 2/3 of the tracts are bringing information up to the head, into the brain. Because if the brain doesn't have good afferent information from all tissues of the body, it can't make good decisions on how to adapt to that afferent input. So the bottom line is fascia involves the whole body, and it completely interconnects and interweaves all the tissues together. Now, van der Waal calls a dynamite, the joint's a dynamite system, and we're going to go on to that in a minute here. So this is Van der Waals' work, where he describes man as the muscle man, where we're usually described how muscles attach to bones and move things. And he's saying he likes to look at the system from an architectural design perspective. And what his fascia work showed, that the fascia from the muscles continues down over the fascia of the tendon, continues down over the fascia of the ligaments, over the capsules, continues on across the joint and from side to side and front to back. And the interconnecting all these through this fascial thing. And so he says, instead of using the term ligament, he used dynamite. So these things are dynamic and move and have adaptability. And normally we would think if we flex our elbow, then the inside of the elbow is going to get lax, the outside of the elbow is going to get taut. But what Van der Waals work shows is that this dynamite design enables the fascial tension around that joint to be appropriately tensed, no matter what movement they're in, position they're in, or what function is being performed. So it's a body-wide system, and it's a cybernetic feedback loop system. Fascia, as Van der Waals describes it, as the inner being, or the in-between layer, and which develops into the organs of posture and the locomotion system. So here's where we're going brings us right back into the biotensegrity concept. Fascia is derived from the mesosome of the embryo. And plus it also contributes to the development of the parts of many visceral structures. So this ties together a lot of the viscera mechanically, as well as terms of being connected by innervation, etc. So mechanotransduction is the concept that Still was looking for. He saw it as a phenomenologist, but he didn't have the concepts and the language to describe it. But now Ingber has described that, how that mechanism works. Now, let's look at the mesodermal layer. It contributes to the connective tissues, fascia, cartilage, bone, striate, and smooth muscle, myocardium, pericardium, blood and lymph vessels, kidneys, ureters, adrenal cortex, gonads, tubes, uterus, and upper vagina, the serous membranes lining the thoracic, the abdominal, and pelvic cavities, the GI fascial support system and spleen are all derived from the mesodermal layer. So doesn't that really make a visceral mechanical connection that lots of times we don't appreciate? And so if there's mechanical dysfunction in the musculoskeletal system, it may have a profound effect on viscera because of the common origin. So the somatic dysfunction then can impact both the musculoskeletal system, and through the mechanism we just talked about, may have a profound effect on the viscera. Now, let's look at some of this data then that we've gone through on tensegrity from an osteopathic perspective. And like you said, not from just a manual medicine perspective, but from a primary care level perspective. So here's an interesting slide of Netter showing what we all were taught about the autonomic nervous system and how all the viscera are basically dually innervated by sympathetic and parasympathetic innervation. Unfortunately, there's a little exception over here on the side that says a blood vessel, a hair follicle, and a sweat gland. And but basically the mental picture that most of us had going through medical school is that's the picture of the autonomic nervous system. But Irving Corr was my physiology professor at Kirksville, and he really thought outside the box. And here was the diagram he used to teach the autonomic system to us. And look at on the left side, you can see that the musculoskeletal system is solely innervated by the sympathetic system. There's no parasympathetic input. And that's why a little bit of thoracic or rib cage dysfunction can have a profound effect on those sympathetic ganglia and affect circulation all over the body, depending on what areas are impacted by that dysfunction. Then I found this similar article. This is out of Encyclopedia Britannica in 2007. And basically it's Corr's picture. Again, you can see on the left side with the musculoskeletal system, you can see the hair follicle and blood vessel that Netter had, but you can see the whole musculoskeletal system listed and solely innervated by the sympathetics. Then you see on the right side how the viscera are dually innervated by sympathetic and parasympathetic. But there's another big exception that Corr pointed out to us, and that was that the musculoskeletal system could be looked at it as a very unique way. And the way Kors did it was, he said, think about it. Our central nervous system would be totally useless to us without a functioning musculoskeletal system. You couldn't walk, you couldn't talk, you couldn't play golf, you couldn't deliver babies, you couldn't do surgery, you couldn't do housework, you couldn't do anything without a functioning musculoskeletal system. So Core called the neuromusculoskeletal system the primary machinery of life, and that was the system of the body that we carried out the activities of daily living. See, and that would correlate with the inner or posture locomotive component of van der Waal. And then remember that the sympathetic system is solely innervated by the sympathetic nervous system. But also look at the vasculature is also in that lower right picture, and then again of Netter, showing that the sympathetics innervate the whole vascular tree. But look at Core was really ahead, because what he showed was the sympathetics innervated the vasculature in the upper half of the body, this middle part of the body. But look at in the lower half of the body, there's parasympathetic innervation to the vasculature, and that enables sexual function. So there's two huge exceptions in the body in terms of every tissue being controlled by both sympathetic and parasympathetic. The vascular tree and musculoskeletal system, they're basically innervated by the sympathetic system. Now, then in this model, then the secondary machinery of life are the viscera. And what's their function? Their function is to meet the metabolic demands of the primary machinery. So if we're all sitting quietly watching this lecture, we don't have much of a heart rate function, pulmonary functions, minimal, GI, liver function, renal function. But if I said to you, I want you to all get up and we're going to run 200 yards as fast as we can and come back and sit down, heart rate would be up, respiratory rate would be up, cardiovascular or renal function up would be up, liver function. Why? Because they're trying to meet the demands on it by the primary machinery. So why is this important? I ran a hospital-based OMT service for 5 years up in Waterville, Maine. And many times I'd have a consult to treat somebody who had gone into cardiovascular failure, respiratory failure, and they had done everything medically they could, that was known to be done. And they were not getting a good outcome. And they say, hey, would you see if there's a mechanical component, a Biotensegrity component to this? And walking into the room in that, with that concept, I started thinking about, primary, secondary sheet machinery whenever I see a patient. And with that perspective, many times I'd go in and say to the patient, now, you've gone into failure here. Let me ask you a few questions. Is there any possibility you had a fall or an injury in the last 6 months? And many times the patient would say, oh, yeah, I fell down, hurt myself and hurt my hip. And that hip hasn't felt right since. And I gimp around on it, but it's not nearly as bad as it was before, but it still bothers me. But many of the PTs will remember the work of Inman and Saunders in the 80s. And they showed that minimal dysfunction in a foot, ankle, knee, or hip could increase the metabolic demands on the whole system by up to 300%. Well, what's it going to be going up and down stairs? So then that explained why that patient went into failure. So not only did we treat him from the medical side to get him balanced out, but then we would try to get that musculoskeletal system and that hip working better before there was, and many patients had a marked increase energy component reserve. So the allopathic disease model, the viscera of the primary machinery of life. And to the allopathic disease model, the secondary, the musculoskeletal system is really secondary. And that's why Netter's slide is so appropriate as an MD. He didn't include the musculoskeletal system in his autonomic picture. Now, I get a kick out of my allopathic friends who claim they practice holistic medicine, yet they ignore 2/3 of the total body mass, the neuromusculoskeletal system. And they ignore it unless there's a cancer, fracture, infection, or some other injury to the musculoskeletal. But otherwise, they think it can pretty much be ignored. So I think this is really a more accurate picture now of putting in the musculoskeletal system and the Biotensegrity system into that picture. Now, let's go look at this from another little perspective. And in this description, the host when I talk about host, I'm talking about the Biotensegrity Dynamite designed patient. And OPP stands for Osteopathic Principles in Practice. So I look at it as the host or the patient can have a disease process, and how that works out, that is the illness or the clinical presentation. And you can get three varieties of that. There are three options. One is it can be mostly disease, not a lot of host, but the illness emerges. These are the people that respond beautifully to traditional allopathic care. They don't respond well to osteopathic care. Then there are other patients that can, from the illness component, can look exactly the same, but their disease process is not as big a player as the host component. These people respond beautifully to osteopathic care and don't respond well to traditional allopathic care. But then there's another group of patients where the host and disease are pretty comparable. And it doesn't matter whether you start treating them from the disease side or the host side, you're only going to get about a 50% effectiveness. Whereas if you put the two together, then you get a lot better outcome and the outcomes that you would normally expect or hope for. So when you walk into the room, when I walk into the room with a patient, I don't know which of the three that patient's operating in until I do my history, my physical, and my structural exam. Then I can start to get an idea of which of the three that patient's functioning in. So ideal osteopathic management then would be, I'm going to rule out any serious or acute problem that needs to be treated allopathically. That's got to be done. But when I was first in general practice in my early career, it was fun because many times patients would come in and I'd say to them, I do my history, my physical, my structural exam, and I'd say, you know, today, the way I would say it is, I think there's a lot of host component in here. You're not acute. You don't need care right off or you're going to die. Let me treat some mechanical stuff in here and then let's see what's left over and we'll treat that allopathically. And when I did that, it was amazing. Lots of times you use far less medication, use lower dosages, shorter durations of pain, had less side effects from medications. It was a fun way to do general practice. Now, to get good results with OMT, I got this from Mitchell. I think you got to start at the key area, the area of greatest restriction, or some prefer the term hindrance, because if you just chase pain, I can guarantee you manual medicine isn't going to be effective, because many times where the pain is in that Biotensegrity system is where the system can't adapt. And so if you treat what it can't adapt to, then many times the pain starts to alleviate. The other thing is translation is extremely important in manual medicine, and especially when you're doing a diagnosis. So say I have an upper thoracic dysfunction, I could have a thumb on either side of say T3, and I could have the patient flex their head forward and back, and I may not feel any dysfunction in there at all. But if I say to the patient, I want you to flex your head forward, but lean back towards me and let them glide back until I get that vertebra at the apex of the curve, many times right at the end, that vertebra will side bend and rotate like everything. And if I hadn't used translation, I would have missed that. And then the extended ones, lots of times, if you just extend their head back, you won't find it. But if you say, I want you to simultaneously bring your head and shoulders back and push your stomach forward, and then glide your palpating hand forward and back to get that vertebra at the apex of the curve, then again, right at the end, that thing will shift around. So many people miss the key dysfunctions because they're not using translation as part of their diagnosis. But translation is also important in treatment. And if you put the patient put the flexion extension component in first, then that markedly restricts the side bending and rotation. Then you don't have to have the patient twisted around like everything, way side bent over. You can keep them pretty much in the midline and get that vertebra at the apex of the curve and use translation and flexion extension, side bending and rotation. And man, when you localize your forces that way, you get some unbelievable results, whether it's an indirect technique or a direct technique. Then it's also important to match the technique to the restrictive barrier. And we'll talk more about that in slide 25. So a lot of the techniques I use, I like them because they integrate regions. So cervical, thoracic, and lumbar, or thoracic and rib cage, cervical and upper extremity. And the more you can integrate regions, the better you're going to get results in with the manual therapy side. So my treatment goal is basically not to get that patient pain-free, but it's to help them realize their health potential. And that's way beyond being asymptomatic. Now, let's expand on that. So if this cell schematic, any pathologist would tell you for the yellow area of the cell, for any tissue in there to be healthy, it has to have a good arterial supply. It has to have a good input from neurological input from both the sympathetic and parasympathetic. It has to have a good flow of neurotrophins into it. You have to have a good functioning rib cage, because remember, the functioning rib cage is the pump for the venous system, the lymphatic system, and the ventilatory system. And so patients can have somatic dysfunction. And what I'll do is place the disease that I'm dealing with in that sphere. Then I'm asking myself, where are the sympathetics are going? Where's the parasympathetic coming? Where are the trophins coming? Is the thoracic and rib cage working right? Because somatic dysfunction could impact any one of those arms, all of the arms, or any combination. And that's why you can get such a wide clinical presentation with people with the same medical diagnosis. So I'm always trying to look at what's going on. Now, there's other terminology now in the complex sciences that I just want to touch on a little bit, because it gives us language to help to better understand biotensegrity and, I think, osteopathy. And one of the things I want to talk about is fractal or chaos physiology, which is nonlinear. And those people are saying we got to get away from the term homeostasis, because that's a reactive term, and that what we need to be talking about is homeodynamics, what is an anticipatory effort. So what does that mean? Well, look at Netter was so far ahead of his this is a slide from the early 70s, and we got a guy on an exercise bike, and homeostasis would say if he starts exercising, he's going to start getting pH changes, blood gas changes, and therefore the heart rate and respiratory rate are going to have to go up to compensate. But look at that slide. The heart rate and respiratory rate went immediately up, and the blood gases and pH did not change. Well, that's not homeostasis. How do you explain that? Well, this slide shows that you have mechanoreceptors in all the joints of the body, but in this case, the knee. The first neuron goes to the cord. The second neuron goes to the respiratory center. And that's why as soon as that starts exercising, the central nervous picks up on it. They're starting, the primary machinery of life is starting to function more. We got to get the heart rate and respiratory rate up to meet that and to keep the blood gases and everything normally. So there's Netter had it way ahead of his time of fractal physiology. And autopoiesis is dynamic structure and function changes. And think about what we've been talking about, the Tensegrity system and how it can adapt and adjust and things. So we don't have time to go through all these right now, but we will touch on them a little more in a few minutes. But I just wanted to show that there's multiple new ways that we can explain both osteopathy and biotensegrity. See, and then once you've treated somebody, and then think it backwards, then you can come up with a patient-specific pathophysiological hypothesis of that patient. For example, I've seen patients who have asthma. They're wheezing, they're on all the drugs, they're on their medications, they're taking their inhalers. That hasn't helped them at all. Screen them out, find an upper cervical dysfunction or an occipitopetrosutral dysfunction, which is the jugular foramen and the vagus going through there. And remember, somatic dysfunction can either stimulate or inhibit the related nerves. Well, if that stimulated the vagus, what's that going to cause? Bronchial constriction. And many times, as soon as you effectively treat that, the asthmatic attack stops. Other patients, the upper cervical is fine, but it's all upper thoracic and upper rib cage. And that's where the sympathetics are. And like I said, if that dysfunction inhibits those sympathetics, then they're not going to have the bronchial dilatation that they need, and their medication isn't going to work well. But also that can affect the sympathetic vasomotor supply. And maybe the patient has a good blood level of medication, but they don't have a good tissue level of medication. As soon as you treat that dysfunction, then the medicine gets where it's supposed to go. And that's what helps to abate that asthmatic attack. But there's how you can correlate the allopathic and the osteopathic. Now, in the States, we're in a process of merging all the allopathic and osteopathic systems into one ACGME regulatory system. And in all their educational meetings, you have to talk about osteopathic integration, medical knowledge, and patient care. And see, and what we just went through in this slide gives me all sorts of ways of being able to explain any disease process from both a biotensegrity and from a traditional allopathic approach and osteopathic approach. Now, this slide, the diseases of mechanotransduction. Some DO specialists say, well, osteopathy isn't indicated in the specialties, and it's just they're too lazy to learn it. But anyway, in the Annals of Medicine in 2003, Ingber published this article about the diseases of mechanical transduction. And what's that all about? Well, if we look at this slide again that we saw before, Ingber's slide, showing how the integrins can change biochemical and genetic expression, Ingber is saying that explains how mechanical factors can affect physiology. And so Ingber is saying, in what systems is this applicable? Cardiology, dermatology, gastroenterology, neurology, nephrology, oncology, ophthalmology, orthopedics, pediatrics, pulmonary medicine, reproductive urology. See, therefore, biotensegrity is integrated, could be playing a role in every one of those systems. And in the center here, we have a list of 44 diseases, and he's saying this is only a partial list of the diseases that mechanotransduction or mechanical factors could be playing an etiological role. So I think it's interesting. A.T. Still in 1870 said mechanical forces can play a role in visceral problems, and everybody said you're crazy. But in 2003, Ingber is saying still, yes, you are right. Now, one other thing that it plays a big role in my practice as far as biotensegrity, and this came about out of some work with Bob Foreman, who is the chair of the physiology department at the University of Oklahoma School of Medicine. And what happened was he had me come in and talk to his physiology department 3 or 4 times a year, and any of the physiologists who wanted to attend could attend. Well, one day when I showed up, they said, oh, we're glad you're here. Joe over here has got a tennis elbow and he's had it injected 3 times with a steroid and it's not helping. How would you look at that from an osteopathic standpoint? So I had him sit down, had his arms at his side, had his elbows at 90 degrees and pronated both wrists, and the left wrist would pronate so the hand was parallel with the floor. The left hand could only get to about 45 degrees from being parallel with the floor. And it had a hard end feel, whereas the other side had a normal spring when you got up against the restriction. So that was the restrictive barrier, or the normal physiological barrier. Then the other was the restrictive barrier, and it had a hard end feel. So I had them all come up and do that exercise, and they said, "Oh yeah, we can see that it's not parallel. We can see and feel it, how it doesn't move as far, and it has a hard end feel." And I thought, great, I just got a bunch of physiologists to palpate somatic dysfunction. And then I thought, but boy, that feels chronic. I hope that's going to change, or I'm going to look like a jerk. And so I thought, with physiologists, I'm going to use muscle energy. So I said, the basis of muscle energy is you're functionally changing the origin insertion of the muscle. So if I take that wrist and pronate it up against the barrier, hold that wrist firmly, and have him try to supinate and resist it, then the supinators, I functionally change the origin insertion. Now that muscle will pronate the radial head. And when I did 2 or 3 efforts of that, and it popped, and when they rechecked it, he had full range of motion, and they all said, that hard end feel is gone. How could that be? And Bob Foreman said to me, Ed, how do you explain that? Tissues can't heal that fast. That had a hard chronic feel and it's gone like that. How do you explain that? And I said, because it's, I think it's a feedback loop. Let me get I think it was the feedback loop, pain, spasm. And then once I reestablished normal motion, I broke that down. And Bob said to me, you're absolutely right, but you missed a big part of the problem. And I said, well, I'm a slow learner. What do you mean? And he said, we've taken dogs and stimulated a muscle spindle in the paw of a dog. And you are absolutely right. It sets up a cord reflex that will keep going on, but the firing is minuscule compared to the firing it produces in the cerebellar and sensory cortex. And I remember thinking, oh my God, because that's where all the patterning takes place. So I started thinking, we started talking about, could it be that somatic dysfunction introduces all sorts of adaptation in that cerebellum? Is that like introducing a virus into the software of a program? And then does that alter the efferent flow out of that and affect the mechanics from then on? So then are we treating the primary cause or the secondary cause? And is this really a primary hardware problem, or is it a software problem? And I think in my practice, most of the time, about 70% of the time, it's more of a software problem like we're describing here. So lots of times, are we treating the cause or the effect? We have to ask ourselves, I think. Now, then this book came out, or this ebook came out in 2008. So 14 years later from this discussion. And I was fascinated as I scanned the book because here's the same picture. Now, I had lectured at Ohio University multiple times before 2008 at the osteopathic school there. So I think this author may have been in one of my lectures, but I thought that's pretty neat. He's using the same picture to describe neurophysiology. So that's why I want to treat the area of greatest restriction or greatest hindrance. And because I don't want to be treating a secondary dysfunction or a compensation, an adaptation, because I'm not going to get a good outcome if I do that. I'll get a change, but it's going to be short term. And then this would start to explain if we're impacting the cerebellum. Another reason why neurologically you could get profound changes throughout that biotensegrity system due to that taking that analogy of the virus out of the software. So then I said to Bob Foreman, Bob, how do you teach the cerebellum to your medical students? And he said, the cerebellum is like the secretary to the 4 proprioceptive tracts. And it takes in all the incoming mail from them. It organizes it into organized packages, then presents it to the cerebellum and the sensory cortex in an organized way. And I thought, whoa, what a neat way of explaining it. And seeing, because you can get these dramatic widespread changes, I think that was why Still had the nickname, the Lightning Bone Center. Now, a lot of people think that's because he did high velocity. I don't buy it. I think it's more that I can treat one little dysfunction in the area and have a profound effect on the whole body, not just that one area. So here's some of the newer complex science stuff and why I think this is puts things into perspective better. And it was the Annals of Family Medicine, 2014. And the title was Complexity in Family Practice, Systems and Complex Thinking. And it listed all the concepts that needed to be taught in the start in 2000 in the science, in the family medicine residency programs. And look at, they're talking cybernetics, general systems theory, complex sciences, fractal geometry, chaos or fractal physiology, autopoiesis, emergence. Each, think about all these systems, each have their own nervous system. So the systems within systems, multi-agent modeling. So I think all of these terms are applicable to allopathic family practice care, but they also apply to biotensegrity. And what I find is missing from that picture is biotensegrity. And think about it, if it's MD Family Practice Journal, they're not going to be focused on the musculoskeletal system. So all of these concepts are new that don't challenge osteopathic principles, concepts, or do they challenge the biotensegrity concepts? In fact, I think I'm going to show you that they support both. So let's look at the complex science. So cybernetics, we talked about feedback loops. General systems theory, then you're looking at one system in detail. Looked at how we looked at the fascial system. Then complex sciences, you're looking at multiple systems. Well, the fascial system can't work without the bony system, and they can't work right without the nervous system, and they can't work right without the arterial system. So again, we're into general systems theory here. With fractal geometry, what's fractal geometry? The things divide, and they don't have to be identical, but they call them as self-similar. Well, that's the design of the nervous system, the arterial system, the bronchial system. Why? Because you can rapidly move air, blood, or impulses through those systems to diffuse areas throughout the body and do it rapidly. Well, could mechanical dysfunction impair that fractal design? We talked about chaos physiology. We talked about autopoiesis, dynamic changes, multi-agent modeling. See, and we talked about asthma as a good example, that the musculoskeletal may have set it up, and that to actually treat that patient, then you had to treat them medically and osteopathically. And some patients, all they needed was the manual approach. Same with peptic ulcer disease. Many people with all the treatments for peptic ulcer disease are using anticholinergics and things to block the parasympathetic system. But many times those patients have mid-thoracic dysfunction around T5, T6, T7. That's the innervation to the upper GI tract. If that's inhibiting the sympathetic and you've got a normal parasympathetic, is it going to act like a hyperparasympathetic system? Whereas then you get that dysfunction out and do the normal sympathetics kick in, and that also could affect vasomotor supply. So now they're getting better circulation to that stomach. So now that ulcer can start to heal and heal more quickly. And emergent properties out of all this maze is what the patient presents as. And I love William Osler, the father of US medicine. He had a great quote one time. He said to a bunch of medical students, he said, you know, what you've learned in the 4 years of medical school when you're studying about diseases and syndromes and everything like this, you're learning like the tune, the melody of a tune. But they said the problem is many of the patients you're going to see are jazz variations. See, and those are the patients that the memorizers can't handle because they've never been taught to problem solve. And you've got to work your way through their maze. And is it a host or is it a disease? Is it biotensegrity? You got to weave your way through that maze and treat that patient. Now, how, in light of all this complexity, how do I clinically view my patient? Now, in Kentucky, they talk about Gordian knots. And I see each patient is like a Gordian knot. And how you make a Gordian knot, you take a long rope and splice the ends together, then tie a knot in it, tie a knot, take other ends and tie knots, and you end up with this Gordian knot that many people think are impossible to solve. So I see the patient as a complex, dynamic, interconnected, interwoven, multiple simultaneously functioning systems which are nonlinear, non-Newtonian, and they're autopoietic, and it's a function, and this is all a functional unit. Well, to me, that is one big dynamic issue. And I want to weave my way through and find the air grace restriction, then the next area, then the next area, and the next area, and weave my way through that complicated mass. So think it, the patient can come on with musculoskeletal problems, but that musculoskeletal problem may initiate a somatovisceral reflex and start to affect the viscera, and through the mesodermal connected layers affect viscera. But also the patient may have visceral stuff that could refer pain to the back. So that patient that comes in with right shoulder pain, you better make sure they don't have gallbladder disease. Now, so each patient then is a jazz variation, and I think then it's fun because each patient that is a challenge. So A.T. Still in the late 18th century said the body is a functional unit. Structure and function are interrelated. It's a self-regulating system, and rational treatment should be based on those three above factors. Now, when I hear that, I believe it, and I think it's great, but to me, it just kind of sits there and does nothing. But think about all the complexity and the dynamic nature of that we've been describing, and how a little somatic dysfunction could markedly affect that and impair its function. And so then my job is to find the somatic dysfunction hindrances in that system, remove them, and let that system go back to its self-healing potential. So some basic concepts. When I walk into a room with each patient, I want to think, why does this patient have this unique situation today? Why? And I've got to realize that each of them have followed a complex and unique route to get to that position. So each patient I look at as one of a kind, and what works for one doesn't work for the next 100. And you tend to think, oh, when you treat a patient, get a good result, you think, oh boy, I've got this figured out. No, you don't. Every patient's unique and one of a kind. So therefore, I teach my residents, you can't cookbook OMT. You got to problem solve it. Then I want to start to evaluate from the perspective, why are they having this problem now? Why not a week ago? Why not a month ago? Why not 6 months ago? Say, and boy, you get a different history when you walk into the room with that patient, because I'm asking myself, what lowered their resistance? What increased their susceptibility? See, and I got this thinking came from core again. And so somatic dysfunction could affect somatovisceral reflexes. Somatic dysfunction could be secondary to visceral somatic reflexes. So I've got to take that into my context of my biotensegrity. Once I establish a working diagnosis, I ask myself, is this a real acute life-threatening problem? And if it is, then I've got to refer those patients. But fortunately, most of the patients I see, they're referred by specialists. So we see people from cardiology, pulmonology, gastroenterology, urology, pediatrics, OB-GYN, peds, physical medicine and rehab. We get referrals from all these patients. And when we use this approach, we can help many of those patients realize their health potential. So then I'm going to ask myself, is there somatic dysfunction present? If there is, I want to diagnose it. Then if I diagnose it, I want to sequence my way through and treat the area grace restriction, then rescreen, find the next area grace restriction, then rescreen. See, and when you treat the first area, you may change 30% of the dysfunction in the whole body. The next dysfunction may treat 20%. The next one may treat 20%. So you've treated 3 dysfunctions and changed 70% of the dysfunction in that patient's body. Well, that's efficiency. And then that makes it fun. So it's like playing osteopathic dominoes. Once you've treated and observed the response, then think it backwards and come up with a pathophysiological explanation of the patient. And I maintain for my residents, they're also learning how to treat these people medically. They're going to practice better medicine when they come up with this patient-specific pathophysiological hypothesis based on their somatic findings and the response of the patient once the patient was treated. So how do I decide what treatment I'm going to use? If the dysfunction, the area grace restriction is mostly pain, then I'm always going to use an indirect technique. And I prefer to use what I'm going to be showing you is the Laughlin techniques or functional release techniques. Because going away from the barrier, you're not introducing more pain, and you can treat real painful patients very effectively with indirect techniques. If it feels like there's some edema in the tissues, I'm going to use muscle energy techniques, because as they contract and relax the muscles to initiate that technique, that's going to help pump fluids out of those tissues and get the edema out. If it's more muscular, I'm going to use muscle energy, because I want to use the muscles, a prime mover, to reintroduce the lost range of motion. But then I'm also using the muscles they need to maintain that correction. So I think I get a twofer. Not only do I get it corrected, but I'm helping to activate the muscles they need to maintain it. If it's chronic or fibrotic, that's when I use high velocity. But some people that feel it's chronic and they give a history of a 20-year-old injury, and it feels like it's just a real Gordian knot, and you find the key area and start to treat that functionally, and they release like everything. If it's fused, either natural or surgical, then I'm going to make sure with functional techniques that everything is working above and below, so they don't get a secondary disc problem or problem in compensation. So therefore, I don't have any favorite techniques. My favorite technique is what is appropriate for that specific dysfunction. So I don't want to be known as a muscle energy person or as a functional person or high velocity. That drives me crazy when people say that. So most of the techniques that I use are based on what I learned from George Laughlin, who was a grandson of A.T. Still. And his mother was Blanche Still, who was the youngest daughter of A.T. Still. And at the age of 16, she was in the member of the first class of the American School of Osteopathy. And what he role modeled for me is what I called functional release techniques and / Laughlin, because I wanted him to get credit for it, because nobody else was doing it. And I thought I saw him get unbelievable results, and I thought I got to figure this out and try to be able to explain it and teach it. And I want him to get credit for it. And I don't want credit for it. It's an indirect technique. So you're always positioning the patient away from the barrier. So you're basically positioning them at the positional diagnosis point, which I call the dynamic balance point, because when you find that point, boy, it's not times the tissues just start coming alive and it wants to start correcting itself, unwinding. Then I'm going to add a compression stress through that tensegrity system, through the continuous tension system, and vector it down towards the dysfunctional facet pair, sacroiliac joint, or suture. And when you do that, then that body starts unwinding indirectly away from the restrictive barrier. It will hit a still point and you keep the compression there. Then all of a sudden you'll feel the tension in the body shift. And then on its own, it will spontaneously start to unwind away from what was previously the restricted barrier. And they'll usually end up in the position you would have put them in to do muscle energy or high velocity or direct technique. So they're beautiful. And the only thing the physician is doing is positioning them and adding the vector. The rest of it is all being done by the patient. And the analogy I like to use, think if you have a set of bureau drawers that are stuck. If a drawer is stuck, you can yank it out, or you can get in behind and push it out, or you can glide it in, jiggle it till the contents settle, then pull it out. And to me, that's what a functional technique is all about. Now, some of you may have seen Van Buskirk's still techniques. The second stage after the still point, he actively brings them back into their end position, where I would much rather have the patient do that. And I think he got that from a video. He was never mentored by a Still or a Laughlin. And I thought Laughlin was moving it around. And one day I said to him as he's treating me, "Are you doing that?" And he said, "No." I said, "Who's doing it?" "I'm not actively doing it." He said, "No, your body's doing it." And so I think he missed that one. Then I do a lot of muscle energy. And I was in the first tutorial that Mitchell taught in 1970. And he hand selected the 6 participating physicians. And I teach muscle energy as he taught it then, because lots of times now it's being taught in a modified way, and I don't think is effective. And during that first tutorial, Goodman and I were roommates, and we realized that Mitchell was not only an amazing clinician, but an amazing teacher. So he had a big impact on my teaching. And he's the one that taught me how to sequence and to find the kick. And I'll just give you a brief story to illustrate that. One day I was in his office and he said, "I want you to treat some of my patients and I'll just sit in the corner and watch." And I thought I understood his techniques pretty well. So I was young and arrogant, and I thought, great. And I treated the patient. The patient had low back pain and sciatica. And I screened her out, and Mitchell didn't stress his screen, but Laughlin did a screen but couldn't explain it. Wilson had a screen. And so when I saw Mitchell do it, I thought, man, this has got to be important. So I learned functional by mimicking Laughlin because he couldn't explain what he was doing. So I just mimicked the Mitchell screen, and I treated some thoracic stuff, some rib stuff, some lumbar stuff, sacral dysfunction, some nominate. And I thought, man, have I done a good job. And Mitchell's just sitting in the corner in the back of the room with his arms crossed across his chest. And I got all through, and he said to the woman, "Stand up and face me." And she did. And he said, "How do you feel?" And she said, "I don't feel one bit different than when I walked in." And boy, my mouth flew open. And we had a pretty good relationship by that time. I turned to him and said, "So much for your stuff." And he said, "No." And see, what he would have said to me in today's language, he would have said to me, "You are very competent in doing my techniques, but you are totally incompetent in problem solving the way I do." Like Greenman saying, what makes the DO different is not the OT, but how they think and how they problem solve. And see, and he said, and from my screen, he could tell her, and he said, "I want you to retreat the patient. You can't add a technique. You can't subtract a technique, but you retreat her." And I got all through, and he said, "Her stand up and face me." And she did. And he said, "How do you feel now?" And she pointed at him and she said, "Now I feel like I do after you treat me." And I thought, oh, wow, I've got to try to figure out what he's doing. And that sent me down a 30-year pathway of trying to explain it. And Fred Mitchell Jr. has told me that he never could figure out his father's problem-solving thought process. And he came up with his own 10-step screen, but it does not get you to the same place his father got him. And that happened several times that week that he had me retreat people. And when he talked me through the right sequence using the same techniques I had previously used on the patient, got a totally different outcome. Now, another time I was lecturing on finding the key area in sequencing, and Janet Travella was in the audience. And that night, a bunch of us went out to dinner. And as far as I know, it wasn't planned, but I ended up sitting next to Dr. Travella at dinner. And at the end of the first course, they were taking away the plates and stuff. And she turned to me and she said, Ed, that was a fascinating discussion today about finding the key area in sequencing. And I didn't expect that at all. And I said, really, Dr. Travella, what did you find interesting? And she said, I was sitting there listening to you, and I realized for the first time that I sequenced my spray and stretch and my injections and my trigger points. See, and that's why people could take her courses, learn her techniques, but they didn't get the results she got because she didn't realize she was sequencing until that moment. And she said, I did not realize that until today. See, and I think the same thing happened to Mitchell, that he realized that we were learning his techniques, but we weren't learning his thought process. I also do cranial, but I do it use an indirect sutural approach that I learned from Laughlin. And he was in the first cranial course that Sutherland ever taught. And he taught as part of this the Sutherland Teaching Foundation for a number of years. But he taught me a sutural approach, which is a lot different. Then I do some high velocity, but it's basically based on the work I learned from Mitchell and Kimberly. And they used to say to me, learn the principles and get them to work for you. Then you can work smart. You don't have to work hard and you don't have to use a lot of force with high velocity. And then I do some dynamic gait evaluations and treatment stuff that has become a great integrator in the system. So now let me take a few minutes and just go over some of the research I'm doing. But before that, I think it's appropriate to go through some questions. I always ask patients, how do you feel since you got OMT? And lots of times, patient would say to me, well, I still have pain. And I didn't realize that many times people who have never had pain before, if they still have pain, no matter, even though it's a lot less, they don't think they're any better. And so I said, let me ask you another question then. Let's say, for example, your pain was 10 when we started and 0 would be none. Where are you now? Oh, it's a 2. Oh, you're saying you're 80% better? Yes. Whereas just previously they told me they were no better. They still had pain. So that was a real eye opener for me to realize I had to ask about pain in multiple ways. The other thing I found was important to say, what are you doing now that you didn't do before I started treating you? And I'm saying, well, I do housework now. I cleaned out my garage. I cleaned out my car. Yeah, I'm still garage. I'm still having some pain, but boy, I can do a lot more. Well, that's important to get into the record and for you to realize how much you're really helping that patient. If a new pain develops, the first one time that I treated a patient that came in, I treated them 2 or 3 times, they were doing better, came in and said, I've had a terrible week. So when I hear that, I at that time, I would start to think about, oh, what did I do wrong? What did I miss? But I asked a different question that day. And I said, have you ever had this pain before? Oh, yeah. 10, 15, 20 years ago, I had a car accident and the pain I'm having now is exactly like the pain I had then. Well, what I've done is peeled the layers off the onion. I'm back to a new level. Then the patients realized they were being helped through an old thing that they have been compensating for 10, 15, 20 years. So the message is pain can not be a good, reliable source of how much you're really helping the patient. I always want to encourage and focus on, I want the patient to focus on quality of life rather than the pain. Also, sometimes pain, say your stiffness was 10 and 0 and that's 3. Oh, so it's 70% improvement. Yeah. So I still have a lot of pain, but boy, I'm a lot more limber. Well, again, you want to get that into the record. And what I stress with our residents is you've got to become your own advocate with the insurance company because they're not going to do it for you. But if you do it right with these questions we just went through, then they start, and that's in your record, then they start to appreciate the quality of care you're providing the patient. Now, in 2018, I was invited to present a poster, and there were over 300 abstracts submitted for that conference in Berlin. And we've selected out of that 300 to do a poster presentation. And why the reviewers' comments really encouraged me, because they said, our abstract was a good study, well conceived, innovative, and valuable. And why the screen is up, if you put your camera up to that QR code, it will bring up a video up in that upper left quadrant. It's a 20-minute video of me doing my screening exam and telling how I problem solve it, like the exam that I was talking about with Mitchell. But so that project, I want to go through some of the data that was in that research project that has to do with biotensegrity. So what we're doing is the people were on a sophisticated treadmill to evaluate them pre-OMT. Then I took them into the room next door, treated them out, put them back on the treadmill, and we immediately reevaluated to see if we made a change. And we did this with several different approaches. The first one was with using the spinoscope with Grotwiecki. The second one was we added surface EMGs and
Ed, can you hear me?
Pardon?
Ed, I'm so sorry. Can you hear me?
Yes.
Can you go back one screen? Because people are going nuts that they didn't get the QR code.
Okay.
I'm so sorry.
Oh, no. Tell me when to go.
I'm so sorry to interrupt. And I don't know if anybody can catch it and then kind of turn it into a link. So
I can send it to you. I can email just that to you.
I'm trying to do that, but it's not big enough for the phone to read it.
Yeah. Okay.
So we can do it later.
We'll get it to everybody.
Yeah.
Okay, fabulous. I'm so sorry. Please continue.
Okay. And then we added surface EMGs, and then that prints out as an attractor or butterfly and center of pressure changes. And then we decided that there was a lot of world research being done on ground reactive force changes, and we decided to use that model. And the members of the physics department at the University of Oregon analyzed my data. And he said that he's making motor control changes. They're both statistically significant and fractally significant. And we found that so in 80% of the patients that I treat the first time I treat them. And then also I'm going to show you some golf data that I did where we showed it immediately improved club speed, ball speed, distance, loft immediately after sequenced OMT. So the patients who are great diversity of patients, young, old, elderly, overweight, normal weight, underweight, men, women. We had chief complaints of back pain, neck pain, shoulder pain, post-laminectomy patients, post-total hips, post-total knees, headaches, shoulder pain, you name it, we had them. And then also I'm going to show you some stuff with some elite runners. So, and about that, as we were doing this, there's some literature in the States now saying we need more number of one studies, because if you intervene and make a significant change in somebody, that's an important piece of data. Then you can design research projects to support that. But if you put that patient in just with 100 other patients, that significance may be lost and washed out. So they're saying we need more number of one studies. So what you're going to see is several number of one studies. The first study was to demonstrate if Stiles could assess motion and altered motion, the location and altered motion using osteopathic palpatory skills. All subjects were assessed by the spinoscope before and after Stiles assessment and area greatest restriction / sequencing OMT intervention. Plus, Stiles was blinded to the spinoscope results until all the data was collected. And Stiles was also blinded to the medical histories, because before we started this, Serge and I each did a presentation of how we looked at the musculoskeletal system and tensegrity and biotensegrity. And during his presentation, Serge said, lot of people, I think, get led down blind alleys because of the histories of the patients. And I think a lot of doctors get fooled by the histories. And I raised my hand. I said, Serge, I treat by where the area grace restriction is next year. I'm trusting Sean won't give me patients I shouldn't be treating. I'll be glad to do it without history. So that's why I was blinded to the histories also. Dr. Stiles was able to find agreement with the area greatest restriction with the spinoscope in greater than 80% of the subjects, and was able to create statistically significant changes pre and post area greatest restriction sequenced OMT. Now, I argued with Serge on that a little bit because he had the electrodes basically just on the low back region. And some of those people that I treated, the area greatest restriction was thoracic area, rib cage, cervical. So I said, Serge, I think your spinoscope agrees with me 80% of the time, but I'll take that I agreed with the spinoscope 80% of the time. And Serge was there all 4 days working with us. That was a great 4 days. During the second study, we evaluated 5 similar subjects, but added to surface EMGs to the spinoscope. And after AGR sequenced OMT provided by Stiles, the results in terms of motor activation patterns, or older terminology, firing patterns, motor and control, were very significant in all subjects. So again, immediate changes after sequenced OMT. And what we found is exercise programs, protocols did not give the same results. And one patient retained that correction for a year after that one treatment. Now, here's the butterfly or the attractor printout and what that picture represents is a summation of the surface EMG data, the muscle activation data patterns, the center of pressure, balance, gait, and distillation of all total body movements. And what you want is a symmetrical pattern with a healthy variation. This is like musculoskeletal heart rate variability stuff. And look at immediately after that patient was treated, look at the change, became a lot more symmetrical, the butterfly, and look at the changes in the surfacing. So the left picture, on the left side is heel strike, then toe off. Then you have left heel strike, toe off. And look at the immediate change in gait after sequenced OMT. Now, the second one I want to talk about was a 70-plus-year-old male who a year previously had had a low back surgery for stenosis, did very well. And a few days before I just happened to be going out, he lifted something and flared up his back and developed low back pain and sciatica. So we did the ground reactive force. So again, the first hump is heel strike, the second hump is toe off, and you can see there's a lot of confusion on that left side, which would correlate with the left sciatica. When I screened the patient out, his area greatest restriction was looked like a sacral dysfunction, but none of the findings fit a true torsion. Some of the findings did, some of them didn't, but L5 was going in the same direction. And Mitchell always stressed that that was supposed to be a universal joint, and they were supposed to go in opposite directions. And so he always said, if it's out of pattern, treat it first. So all as I treated was L5 with a functional technique because he'd had previous surgery. So I wanted to match my technique to the barrier. And I just treated that, just did one thing, put him back on the treadmill, but immediately his sciatica improved and his low back pain improved. So that with that one thing, look at the difference. So the green is the pre-OMT, the gray is the post-OMT, and look at how the gray is a lot more normal pattern and a healthier variation. And again, that's immediate. But then Cooper, who was running the equipment, said, look, but there's some craziness going on the right side now that wasn't there before. So I took him back in the room and rescreened him. And what we found was a right SS sutural dysfunction, a right greater wing sphenoid frontal suture. And remember, that suture is L-shaped. And where else do you have an L-shaped suture? In the sacroiliac joint. Well, think of the sphenoid and the sacrum are tied together by a long dural tube. Wouldn't it make sense that they'd have joints that be similar on either end of that tube. And that's why many times when you treat that suture, the patient says, I don't know what you just did, but my low back just relaxed like everything. Then other times when the air grace restrictions is in the pelvis and you treat out the pelvis adequately, the patient says, I don't know what you did. And they point to that area of that greater wing frontal suture and say, you just relieved my headache here. So that really ties together. And then he had a right petrious sutural dysfunction. Then he didn't have anything else needed treated. We put him back on the treadmill and rechecked him. He was pain-free. And look at, he had a normal, healthy pattern. Now, the second study I want to do was a young woman, 23 years old, who had migraine headaches for 10 years. She had been worked up all over the Northwest. Nobody could figure out what was going on with her. And she had no family life. She lived in a dark room most of the time. She had multiple migraine headaches per week, sometimes several a day. She wasn't able to hold a job. She came in, she had dark glasses on, full hat pulled down over her head, and looked as angry as a junkyard dog. And I said to Sean, what do you think I'm going to do for her? And we put her on the treadmill, and you could see the green would be the pre, the gray is the post. But look at immediate changes, particularly on the left side. And you'll see why that's significant. Because what I found, the air grace restriction was right occipital petrious suture. And that could affect the vagus and be part of the nausea and vomiting she had. A right SS suture, right greater wing zygoma suture, and a left SSU. And when I started treating the right greater wing of the sphenoid zygomic suture, she said, why are you working there? And I said, because that's the next area of greatest restriction. Why? And she said, I totally forgot this, but 2 years before these migraines started, I fractured that zygoma. Well, isn't that pretty neat? Biotensegrity and screening got me to that area. I treated that area, and the hat came off, the glasses came off. She got back on the treadmill. She didn't have to hold on to the sidebars. She was like a totally different person, just like that. Now, and what was interesting, look at the right side of the cranium would affect the left side of the body. So then that correlates beautifully with the ground reactive force changes on the left side. Fortunately, 18 months later, I happened to be back in Eugene, and her mother worked for Sean Roach. So she had her come back in, and she said, I've got my life back since the first treatment. She was a totally different person. She was outgoing. She was animated. She was happy. She had a full-time job. And her mother is standing there crying, saying, I have my daughter back. And look at so the upper one was the findings pre and post OMT, the first visit. Look at the second visit. She had maintained most of that correction of improvement in the ground reactive force. And when I rescreened her, most of all the dysfunction was around the right orbit. And so then when we treated that out, look at the gray, how then that pattern straightened right out. So a couple of things I want to show is that here's in this case, the blue is the pre-OMT, the red is the gray. This patient, the tension in the body, the system was too high, because normally it should be about 550 newtons at the peak and about 400 with at the lower boundary here. And but look at, and there immediately after we treated her, the red dropped down, and that what meant that the tone decreased markedly in her whole system. And she was within the normal range, 550 and 400 then. And so Cooper said, when he sent me the email, he said, this magnitude is common to what I've been seeing so far. So he was seeing unbelievable changes in the people that I treated. And we have looked at the literature all over the place. We can't find people that are seeing immediate changes after an intervention in the ground reactive force. They show changes with long-time exercise programs and things like that, but nobody else, we can't find anybody else that's getting immediate changes. Now, this case 4 I wanted to show you. Now, this patient, the tension in the system was too low. And immediately after I treated the patient, it went back up the red to the normal 550, 400 range and had good complexity. So what was neat is still had it right. Find the dysfunction, fix it, and leave it alone. A lot of DOs talk about, I got to stimulate this, and I got to inhibit this, and I got to tone this up, and I got to relax this. Our literature says if you sequence that biotensegrity system and you get those key areas out, that the body 80% of the time will go back to a normal, healthy range. And it tends to do that on its own. So the key there is the techniques then were all matched to the restrictive barrier. So it was area grade matching the techniques to the barrier like we described. And then this one, you're again seeing immediate changes, bing, 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 coming right back onto the treadmill. Now, I just put these side to side to see, boy, they can be too high or too low, but boy, when you do sequence, they balance right out. They tend towards a normal, healthy pattern, and they will be both statistically and fractally significant. And so therefore, each patient is like their own research project. Now, let's look at the case 4 again from another perspective. Cooper started superimposing green on the amount of change that occurred during the gait cycle with the sequenced OMT. And in this one, you can see there was a 66% change in the sequence. And look at the statistical significance of that happening are 0.05. That's not too bad for beginners. And I love this picture of Still. He was a phenomenologist sitting, figuring out this osteopathic stuff. Now, the solid line represents the mean of 60 gait cycles. So that means there's a ton of information in there. See, and then they can compare each comparable dot in the two lines for both statistical and fractal significance. And so therefore, there's a ton of data in there. Each page is their own research project and a good study of number of 1. Now, the back pain patient, let's look at that again, because with him, an immediate 100% change in gait in that 71-year-old male who had had a laminectomy, and then I just treated of L5 and 3 cranial things, and we got 100% change in gait. So still had it right. Find it, fix it, leave it alone. And look at the statistical significance here, 0.01. Now, the last one I want to talk about was an elite runner. And for 2 years, she, when she ran, she felt like she could never get her left hip to glide forward over her weight-bearing foot. So she always felt like she was kind of running on an oblique angle. And I put her on the treadmill. See, and I could straddle the treadmill and put my thumbs on her sacral base as she was running, and see, was she going into a left-on-left torsion with right heel strike and a right-on-right torsion and a left heel strike. And she wasn't going into a right-on-right torsion with heel strike. So that made sense to what she was telling me. The history corresponded here. And she had been doing a lot of retraining exercises for several months with Tensegrity PT, and she felt it helped somewhat. So she was really skeptical I was going to be able to do anything for her. So her area greatest restriction was left rib 6 through 10 exhaled. L4 was FRS left. She had left posteriorly rotated innominate, and that would hold the left pelvis back, and the sacrum couldn't go into a right-on-right torsion. And what you can see is it didn't change the butterfly that much. But look at the ground reactive force. So the gray is the post, the green is the pre. And of the 3 elite runners I ran, the amount of ground impact decreased on an average between 7 and 10 pounds, which is huge for a runner to decrease that pounding thing. And see, and with that, it showed that we took on the right literature. And as soon as she got back on the treadmill, she said, I can move freely. I can get that hip over my left foot. I can do it now without effort. And look at, we made the right decision to go the ground reactive force because it showed the changes, whereas the ground reactive force change, or the butterfly and the COP things, they didn't change that much, but the ground reactive force one did. And if there's any white between the two lines, it's both statistically and fractally significant. Now, many of you know van der Waal. He's become one of my real heroes. And he's the first one I ever heard the term phenomenology, because before that, I was calling it Goethean science. But look at this quote of van der Waal. Scientific method of phenomenology is used to create a synthesis between modern orthodox embryology and a holistic view of the human being. The human embryo reveals who we are and what we're meant to be. Practitioners have found that comprehending embryological forces supports a holistic and biodynamic approach to healthcare, because the same forces that form the embryo are continuously at work throughout life, carrying the blueprint of health into manifestation. See, and that's what I see we're doing. We're trying to find the hindrances that Biotensegrity system that's playing a big role in enabling that blueprint of health to be manifested. And we're trying to find those and remove those. And then what we're doing is tapping into that blueprint that's trying to carry that patient to their health potential. So for many years, all of these biotensegrity and complex science concepts for me were individual disciplines. But lately, especially during COVID, since I got a lot of time to just think, they have been blending and merging into a complex, integrated, functional mental picture as I examine the patients and treat patients and try to explain to them what's going on. I now see them as all part of the Biotensegrity organizational foundation, but applicable to specialty and primary care practice. I hope this presentation challenges others to travel down this exciting pathway. I hope I've challenged and expanded your Biotensegrity paradigm and its broad applications for the medical specialties in primary care. And the picture in the lower left quadrant was taken at Big. And up on the stage, Gimberto had just done about a 3-hour presentation about his latest research of scoping under the skin and tensegrity. And it was an nobody moved for about 3 hours. And he got all through and he turned around and he said, you know how he waved his hand across the screen and he said, you know how the only way I can explain all that? He said, Biotensegrity. Well, up until then, the tensegrity and the biotensegrity people, they weren't always on the same page. And I ran over and found Steve. I know where he was sitting. And I said, Steve, I think this is so neat that what Gimberto just said, acknowledged what you've been doing for years on your own territory. And here's Scar and myself talking to Steve, and you can see the grin on his face. That was an amazing time.
Wow.
Thank you.
Wow, Ed, so amazing.
That was an amazing talk.
Let me do a toast before I get through.
All right, we'll do the toast now and then we'll take questions.
Sure.
So I'm just going to say this is out of order. We're going to do a toast.
Okay.
We'll do questions at
That's
some
my sequence, see?
Yeah. We're resequencing in honor of Ed's presentation. At some point, we won't be live to YouTube anymore, but we are going to stay live to YouTube for a little while. And
Okay.
I hop on here, Susan, and request before the toast that we shut off the screen share and invite everybody who's here to turn on their cameras, please.
Okay, great. And so we're going to stay live to video. And so then here's my question. Because we are as far in as we are, maybe we should, Ed, if you're good for time, we'll run through our sponsors again, which we usually do at the end, and just give everybody a peek at what's coming up for next time. And then we'll get to the questions. Is that a good idea? What do you think, folks?
Now, remember, I'm technology challenged. So you want me to shut off my screen sharing?
Yes, that red button.
Oh, okay.
Stop screen share.
Okay.
Ooh, yes.
Wow.
And what about in terms of the sequence, Chris, what do you think?
I think that sounds good. If Ed has time to go through all of that, then we can move through all of
Sure.
our station ID. We'll have a toast, but let's keep the video on so that those people who are watching this later or watching this now on YouTube, we want to be able to hear the responses to the questions.
Great. And so if you can just hang out for a minute, Ed and Steve, we've got a few questions lined up, but first, Graham, if you're ready, let's go over to the sponsors before we do the toast, Ed, okay?
Sure.
Okay, thanks, Susan. Let's just remind everyone that the Biotensegrity Party is an all volunteer production of the Stephen M. Levin Biotensegrity Archive, and made possible in part through the generous support of our wonderful sponsors. So we're all volunteers here, and we welcome your input. And the sponsors help to spread the word, and they keep the whole thing running. First, with Handspring Publishing in Scotland, we have a wide range of authors and books suitable for the movement and manual therapy professionals. And they're offering a generous discount coupon to all those on the Biotensegrity Archive mailing list and our Zoom participants. We're also supported by Embodied Biotensegrity, run by Chris Clancy in British Columbia, which provides an excellent resource for those of you looking to learn more about biotensegrity. Then we have Artifact Pro in Madrid, Spain, where you can find wonderful anatomical tensegrity models. And they also offer us a generous discount coupon to Zoom participants. And the fasciahub.com, which starts a full day of talks on the fascial pelvis tomorrow, Saturday the 28th of November, and there's still time to register for that. And there are several people speaking on that: John Sharkey, Anne Crowell, who spoke last week, Neil Galloway also spoke last week. And finally, Integrated Biotensegrity, who produced a one-day course at the beginning of November. They are having a Q&A session on December the 10th and 12th with Lisa Babiak, Paul Thornley, and Rachel Tudor. So to follow up on Integrated Biotensegrity, check out that as well. Thank you, Susan.
All right, Graham, thanks. And Joanne Avison will also be presenting tomorrow. So you're kind of in the last minute, 3, 4, 5, 6, 7, 8. Yeah, you've got to get in there and buy your ticket before midnight, I think, midnight UK time for that presentation. I am also going to say, I'm going to give you a quick looking ahead and say that next week, Lionel Wahlberger will be with us, and he'll be talking about the Tensegrity Wiki and his history with that. The week after that, which will be the 11th, Steve is going to give his presentation, his most recent presentation that he did in Augsburg a couple of weeks ago. And it is incredibly dense and condensed in terms of really giving a big, wonderful big overall picture of where we are with the science right now. Of course, Ed's presentation from today would give you a wonderful sort of complementary, or I don't know, they would work together. If you did both, you'd be in a really good place. I'll put it that way. And then the week after that, on the 18th, we're not going to be live to YouTube, and we're just going to have a Zoom party. So that will be totally unstructured and a free-for-all. So that should be fun. And then we'll be off for about 7 weeks. We'll be off until the beginning of February, and then we'll come back for season 2. So that is that. Do we have any other announcements, Chris, that we need to make before we go to questions and discussion?
I'm just actually adding the subscribe button to our YouTube channel. So those people who are on YouTube right now can get our newsletter and then join us live at our season end party. So okay. I think that's all that we have. We've got lots coming up for the new year too, but we'll talk about that in a future episode.
All right. And I want to also say that thank you, George Roth just put into the chat a nice kind of introductory thing on matrix repatterning. George is another person who has been working with Steve, friends with of Steve for decades. And so maybe somebody can pop that into the YouTube chat as well. George will be joining us when we come back on for season 2. So we've got at least 3 questions in the queue, but before we go to the questions, I'm gonna let Steve jump in because I think he and Ed have a thing or two I'm gonna give him his moment. Here you go, Steve.
I just want to say that, this is where so much of my formulation of what I did for 40 years came from my interface with the osteopathic community. And of course, I trained with Ed and Phil Greenman and Paul Kimberly and Tony Chila, and this whole group taught me all this integrated medicine, so that I always, it's all part of what Biotensegrity has become. So I brought in the mechanics, but the depth of understanding of it really came through the osteopathic community. And of course, as I said at the beginning, there's no finer teacher than Ed, and now you know why I said that.
That's great. So we do have, thank you, Steve. And Ed, you can't see it maybe, but in the chat, there's just one comment after another of like, bravo, bravo, standing ovation, absolutely fantastic, blah, 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 blah. So just know that everybody is absolutely delighted. Wilbur, you had the first question, but I can't tell if you're actually there or if you've stepped away. So Wilbur, you're up, and Elizabeth, if Wilbur's not here, we'll bump him back and we'll go to you because I don't see Wilbur. All right, going. Elizabeth, are you ready with your question?
I am. And the question that I put in the chat was fairly early on in Dr. Stiles, in your presentation. I was asking if you would address gait in terms of your application of Biotensegrity. However, as your presentation continued, you had those beautiful case studies. So now my second question, Susan, that I'm getting in here is, Dr. Stiles, when you finish your first session with your patients, do you make any recommendations to them as to what to do or not to do in order to appreciate the effects of their health potential?
Yeah, can you hear me?
Yes.
Okay. Because that's one of the neat things of if you use muscle energy, because you can say, see, I'm using muscles to reintroduce movement. And look, I put you in this position that you, now here's some exercises I want you to do. And they see it as a reinforcement. But I'm amazed at how many times, that's why I think so much of it's in the software and not the hardware, that once you get the dysfunctions out, you immediately see the changes that we are seeing in total body function and the ground reactive force stuff. And let me say, a lot of PTs that have worked with me, they've told me they get, the better they get at sequencing and doing this, the less they have to use exercise.
That's great. Okay,
Thank
now
you.
Mariana Barreto is next, but I'm gonna just jump in because my question was number 4, but yours, you just mentioned the ground reaction force, Ed, and so I want to make sure I understand. More ground reaction force measured in terms of that hardness is more potential energy getting kind of stuck in the system,
Yeah.
and less getting translated to the kinetic energy that the athlete and any mover is looking for.
Yep.
As they want to use that energy they're generating with their stomp or their step to translate into the kinetic energy, which then translates into the effortlessness of movement. Do I have that right, Ed? Steve?
Yeah, and I think that's why the significance of the patient saying, I feel weird, I feel taller, and I feel lighter. So that means, man, they got to bounce to their step now. and they're not burning up as much energy.
Right. So less of that ground reaction force getting stuck as potential energy in the system to be released at a later time, and more being harnessed as instantly usable kinetic energy.
Yep.
Great.
You got it.
All right, Mariana Barreto, over to you.
No, it's just like at one point you were talking about the muscle energy techniques, and that you are teaching that differently, or it's taught differently, and then you went into the story of how you learned that, but you said that you would say that and you didn't, so I'm just curious.
Yeah, because in fact, Fred Mitchell Jr., he's been teaching that it's NIP, neuro, I'm blocking out on the term. Huh? Somebody said it. That Carl Levitt talked about. But anyway, Mitchell Sr., he wouldn't have agreed with his son, because he was saying, what you're doing is you're activating a muscle to reintroduce movement into a joint. See, and how he taught, and he said there's two ways of looking at every osteopathic technique. One is the position you put them in reference to the restrictive barrier. Do you go direct or indirect? The second was, what's the corrective force? See, and for a long time in the osteopathic profession, the corrective force was a thrust or an impulse. See, and then Mitchell came in and said, I got a whole new way of diagnosing the musculoskeletal system. And the corrective force I'm using is an introduced patient muscle effort. Man, that turned things upside down. People went crazy. And they fought him like everything for a long time. So because some people are saying you're stretching out muscles, and Mitchell did not see it that way. Post-isometric relaxation, there's what I wanted. Then see, and I don't see that, because once you introduce the new motion, then that stimulates mechanoreceptors. And I think Barry White had it right in the 80s, where he showed that if you stimulate mechanoreceptors, they suppress the pain receptors. And I think then you get more muscle relaxation. So then you get more movement. So that he wasn't stretching the muscle out, he was introducing the muscle. And as he changed the neurophysiology, yeah, the muscles relaxed, but it wasn't a stretching technique. That was a secondary effect.
So it's the mechanism what is different. Like it's still
I think
the rationale behind is what's different, right?
Yeah.
Yeah.
And then then sequencing was very important to him. But I think today the term muscle energy, that's a tough term to deal with allopathic physicians in the United States. And I think today he would call it muscle activation techniques. And that would have been so much easier to explain and to accept into the allopathic model.
Thank you.
That's great. Yep. Hey, Marjorie, I think you're next. Can you unmute?
Yeah, for sure. So my question, as I was listening, I've been looking at this for a while now. I guess I'm curious how much you think the arrival of the concept of biotensegrity did and maybe should or shouldn't change the nomenclature and the words we use in manual osteopathy right now.
And Marjorie, can you just give your background so everybody knows? I know you, but not everybody does.
No, of course. So I'm a finishing student at the Canadian School of Osteopathy and thesis writer right now. So I finished all my classes, and my thesis is on the concept of biotensegrity in osteo and our school.
So like, give me an example of what terms you would think might want to be altered.
So one of the things that comes up a lot is things like physiological glidings in the body, things naturally moving in what looks like translations versus what we call translation lesions or shears. And I've been coming back with different texts that are used for teaching osteopathy, and something that keeps coming back is the words we use, things like lesion versus somatic dysfunctions that create we decide how we define things by the words we give them. So I'm curious how things like that could change with things like levers or joints that were quite important words used in biomechanics, but biotensegrity kind of negates a lot of it, I feel.
Yeah. See, and the terminology is important because when I first met Steve, and we were at Michigan State, the term we always used was osteopathic lesion. But then the MDs that were coming through the program said, you can't use that term because a lesion you can biopsy. You can look at it under a microscope. What you're describing, you can't look under a microscope. So it was Kimberly that started coming out and said, it's the somatic tissues and there's dysfunction. Maybe we ought to call it somatic dysfunction, which I think was the real benefit. Because it was a lot more pliable term. And I found what's got me into all this complex science stuff. When I explain, when I'm off campus and explain osteopathy using that complex science language, MDs buy in so much faster. It's amazing.
Yeah, it's definitely been something I come back to where when we describe what we do to other practitioners of any kind, as soon as you use words like lesions or translations or off axis, things like that, they'll take x-rays and kind of just start debating with you, whereas that's not what we actually claim, but that's the words we use, which that's where I think we get misunderstood a lot.
See, and then when we're starting at Michigan State, the other big one was subluxation that the chiropractors used. See, and that, see, for us, subluxation, man, that's a surgical procedure lots of times is required for it. And so we had to refute that term and say, no, it's not out of place. And it's restricted within its normal range of motion. And we're just reestablishing normal range of motion. Mm-hmm. And once we started talking that way, then MDs started buying into it like everything. And then the other one was the big, it was interesting because all the MDs that came through Michigan State at that time, I always asked them, you're an MD, why are you coming to Michigan State to learn how to do osteopathic manipulation? And they basically all gave me the same reason. I'm sick and tired of losing patients to chiropractors. And that was what turned them around. And I thought that's kind of interesting. So, language, and there's a lot of language problems in the osteopathic profession because a lot of people develop their techniques in isolation. Larry Jones and Shiowitz and all these people, they developed them in isolation and weren't communicating with each other. And sometimes there's a lot of confusion in that terminology. So that's why I've spent more time reading stuff outside the profession than inside the profession.
Mm-hmm.
Thank you. That's great. Chris has a question. Maybe we could do Chris's question and then we could do the closing toast and then we'll continue on to wherever we go in our new sequencing.
Thank you, Susan. And thank you, Ed. What a fantastic presentation.
Yeah, I had an impact.
Oh my goodness. And even this latest little discussion about language, I think we'll have to maybe bring you back on to talk about language. It's a whole separate discussion that a lot of us are wondering about, bringing things together, also the allopathic with the holistic. But my question for you has to do with something you said early on. And it was something to the effect of non-metallic material organized in a tensegrity arrangement can conduct energy. So I'm wondering if you'll say more about this, about the research. My assumption in hearing it is.
Okay. Yeah, and I haven't followed up on that. I need to, but it just, when I read that, I thought, man, that's what I feel under my hands. I'm not a true academician. I'm a phenomenologist, and I learn more by doing stuff and learning and thinking stuff through and picking up something here and here and here, putting it together. But because lots of times where I was doing a lot of teaching with PT groups in the States and some MD groups, I had to look out because I had enough baggage to carry just as a DO, so I was always trying to keep away from that. And some people in the osteopathic profession can make the energy thing really sound weird. And so I was trying to stay away from that. And when I heard that, boy, Tensegrity designed systems that were non-metallic could conduct electrical current, I thought, whoa, that's what I'm feeling. But I should follow up on it.
Well, it's such an interesting question because so many of us are doing exactly what you are. We have this sensation, but we don't necessarily have the science. Well, maybe some of you do. Carol Davis probably has more to say about this, but some of us aren't so familiar with all of the research and the lingo, really. Carol, do you have anything to say about this?
No, one other thing let me say is I got so much good advice from Fred Mitchell Sr. in that first tutorial and working with him. And he said to me, you know, you don't have to tell everybody everything you know and everything you do. and that has saved me an awful lot of times. And so it, and then see if vibration is a form of information transfer. So these are ways that physiologists and neurologists, they're not talking about, but it is another signaling system that's going on that we're changing manually all the time and don't even know we're doing it.
Mm-hmm, mm-hmm. Right. And it's interesting what you say about sometimes not saying things depending on who you're talking to.
That's right.
I think it's possible.
And let me say one other thing, because I believe people can do a lot of things in the energy field. But remember, my main focus is first and second year students, and seeing a lot of students that come into osteopathic schools in the States. Now, 1 out of every 5 medical students in the United States today is an osteopathic student. We're the fastest growing medical profession in the history of the United States. But a lot of them come in real skeptical, see, and I don't want to give them the impression that I've got some special gift or something that I can do, and that if they don't have that, they can't do it. So that's why I keep it basic anatomy, physiology and stuff. And if they start to get into it and want to get into it, I'll let them do it. And it's the same with my residents. I don't stress that with residents. Some pick up on it, some don't. And but I try to keep it really basic so that I can keep with the basic residents and the basic medical students that I'm got my focus on.
All right. Well, before we get into the electromesokinetic organ discussion, and Steve and maybe Carol will both have something to say about that. Maybe it is a good time to turn it over to Ed for the closing toast.
Okay. I want to toast to the researchers and the clinicians who are working on the Biotensegrity to give us better understanding and better explanations. And that I hope that this understanding just gets spreads out and more patients are helped by these concepts because they are so valuable. I don't know how you practice medicine without understanding something about Biotensegrity.
Oh, that's a keeper. That's a great quote. Thank you.
Cheers.
My pleasure. That's humbling to hear the comments.
All right. Let's go into the energetics. Steve, do you want to go first and then Carol?
Well, I don't know where you want me to go with that.
Oh, you don't have to go anywhere. I had seen you unmute earlier when this concept of the electromagnetic conduction.
Well, we're into soft matter physics and liquid crystals and things like that we have been talking about now for several years as part of the Biotensegrity concept. That we're talking that biomaterials are soft matter and behave as liquid crystals do, which are another aspect of soft matter. So you get the electrical effects in that, but so you get all these combined in the soft matter concepts. So our Biotensegrity hasn't been solids in a long time.
You know, another area that people ought to look into that may help to explain this, there's a guy named Pollock out in the West Coast that's talking about the 4th phase of water.
We've dealt with this too.
He's coming to a tea party and I knew.
Oh, is he?
Yes,
oh, he's a neat guy. I got to meet him in Berlin last year. He's an amazing guy if you've never heard him speak. But I think he's got a piece of the puzzle.
Yes, yes. Concepts.
Yeah, and it's great how it all keeps coming around and interweaving back together. Carol, let's go to you.
Well, to bring Pollock up now, I think is the keystone, as Steve often talks to us about the placement of the stones. Pollock is the keystone to me, and Ingber. Pollock and Ingber together.
Yep.
If you understand their principles, you can understand how this is being carried out. But like Ed, my students used to say, I really like what you're doing and I like the results, but do I have to believe in this energy stuff? Can I just do this and not have to deal with the energy stuff? And I say, sure, of course, because you're dealing with, it's like, do I have to deal with gravity? But you don't have to focus on gravity. Gravity's going to work no matter whether you're focusing on it or not. Energy's going to work. But the key for me is we have to somehow find a way with our language. I think I agree with everything that you were talking about in terms of language. But the language itself puts barriers up right away. As soon as somebody hears energy, as soon as somebody hears something that we can't measure, something that we can't see directly, I don't want anything to do with it, because that's witchcraft. That's snake oil. And your profession and my profession both have been criticized for that. But the fact is that the most critical thing, I think, is found in some of you have been on the chat line saying what Ed has been talking about fascia finding its way home. That very, very little effort or positioning. It's a sequencing. It's reading the patient. I have colleagues and I like to try to do this too, that intuitively read. That restriction is pulling me to have them lie on their side. But let's get them down supine first to see what the body says to me then. And all of a sudden something shouts out to me that's very different than I saw in standing. And I'll eventually get to what I saw in standing, but I go through an indirect approach, a backdoor approach. And then the patient is always leading. The patient is letting me know how can I put just the right position, the right pressure, and then feel what's happening intuitively, not in my left brain, but in my right brain. Feel what's happening intuitively, following that tissue. And as Ed was talking about the unwinding process, following it, allowing it to go back home. Now, here's the critical key, and this is what I picked up with Barnes. That critical key, and Ingvar talks about this too, is we are reestablishing a vibrational communication system that's been interrupted. And the reason that the whole biotensegrity matrix isn't working in a coordinated systemic way as it's supposed to is the communication is interrupted. And what's interrupting the communication? The fascial restriction, whatever it's bony or whether it's collagen or whatever it is. And it's that vibrational opening up that's going to open up the communication system. Now, it's not verbal like you and I communicate. It's a biochemistry communication that Ingvar talks about, that you talked about, Ed, with the integrins. And you position the integrins in a certain way, and the cell gets a different communication. That's all we're doing with the mechano and proprioceptors, with our hands and our energy. And that, to me, is the most, I don't care whether you use energy or not, but what is most important is the patient is finally able to receive the communication that it needs in order to then be aligned and get rid of the problem.
Let me comment on that, because one time I was teaching a functional course in California, and this woman had a low back problem, had a sacral problem, and I treated it functionally. And I got all through, and she was an MD, and that was her first exposure to osteopathy. And she stood up and she said, "That's amazing." And I said, "Really, why?" And she said, "Can I say something?" And you don't know what people are going to say. Here I got an MD. And she said, "None of you know anything about me, but before I went to medical school, I was a professional ballerina. And most people don't realize, for a ballerina to get into certain positions, they have to have a partner that knows how to properly support them. And when they do, then they can get into positions that otherwise are impossible." And she said, "It felt like I just had the best dance partner I've ever had." And I thought, yes, that's blending in with the tissues, blending in with the mechanism, and flowing with it.
Oh, there's so many ways that we can communicate energy: through music, through sound, through position, through nonverbals, through the environment. The environment of our treatment areas communicates so powerfully to people who are not feeling well.
Yep.
Thank you.
One word that it might be very helpful in this context is semiconductor. And we know a lot about the living tissues and their ability under certain circumstances to be readily transmitting charge, and under slightly different circumstances, less able to do the same thing.
Right, and James Oshman's work explains that beautifully, Neil, about the soft tissue. And as Steve said, this is soft tissue dynamics. We're just really discovering it. But Oshman talks about this beautifully, about fascia is a semiconductor. That, and by semi, not a superconductor, all the electrons aren't going in one way, but there are enough electrons going in one way to open up that channel of communication.
Yeah,
Right.
I've talked about the tensegrity structure as an oscillator since I first talked about it in the 1980s.
Right.
And oscillators give all these sounds and communication and all electricity, whatever you want out of an oscillator, you can get it. So
it's vibration.
Yeah. So the vibration. So this has been part of biotensegrity since its onset in the 1980s, way before Edenberg even talked about it.
Right. And that idea of a semiconductor has to do with the fact that the energy, the electrical energy is regulated, is structurally regulated, and can be optimized in terms of what the flow throughput should be for the system.
Right.
I'd like to ask George Roth to weigh in on this. George, if you could. Can you?
Yeah, I'd be happy. Yeah. So yeah, this is a key to how I feel we can talk about these concepts for sure. And I think that's really helpful what you said, Carol, because the idea of energy is usually fraught with a lot of skepticism, but it really is the basis of everything we do when we interact with the body. But now we have tools to actually measure this quote unquote energy. I mean, I use the example of someone doing electrocardiogram, and you put leads on the extremities and you can pick up the impulse of the heart radiating through tissue, which is truly a semiconductor. What I've sort of discovered sort of by accident is by placing a normalizing bioelectric field over the body. We've used pulse magnetic field devices. We've developed some magnetic technology. We can actually turn these bioelectric interferences. So what happens is when there's an injury, I believe, that there is some resistance created to this semiconduction property. And so areas of injury may be seen as resistors or even capacitors. And when you apply a normalizing field to it, or you apply manual therapy, which creates a piezoelectric field, take that tensegrity structure, which is really, as Stephen explained to me many years ago, it absorbs energy and it becomes rigid. Ingber talks about that too with linear stiffening. And that now, instead of being a good semiconductor, a very flexible semiconductor, is an expanded rigid resistor or capacitor. And that when we apply therapy to this, whether it's to muscle, fascia, in my opinion, bone is very amenable to this as well, along with a normalizing bioelectric field, we can facilitate that release and that change in the tissue properties to bring it back to its normal state. So I think we have great science now that's catching up to this. There are studies done on the dielectric properties of bone that have been used. Hansma, I don't know if you're familiar with Hansma's research. Is everyone familiar with his work on how bone changes shape with injury, how it expands? And yeah, so I did put that in the link. There's a link to one of his articles. He and I have been communicating for the last few years. His work at the University of California has shown that bone literally enlarges with injury, which is what I've been saying, noticed over 40 years ago. And I said, well, wait a second, if bone is changing, first of all, how is it affecting articular structures? How is it affecting fascia? And is it treatable? And we've actually been shown that we can restore bone to its normal shape. We have X-ray studies now that have shown that. We've taken bone that has not responded to treatment, like non-union fractures, and we've restored the integrity of bone. And when you do that, to me, it's another component of the tensegrity matrix, which really has to be considered. And I think it's all part and parcel of what you guys are talking about. So it's pretty exciting. This is my first adventure into your group. I love the discussions. I love the ideas floating around. So I'm delighted to be part of this. So I hope to share some of that with you if you guys are interested. I did post my website there, and do have an introductory seminar coming up. So Steve's been my mentor for many, many years. He wrote forward to a book I wrote in '95, which is based on Larry Jones' work in positional release. So Steve, it's lovely seeing you again. You look great. We're a bunch of old timers here, a few of us. So yeah, that's all I wanted to say right now. I don't know if anyone has any thoughts or questions for me.
Well, you can put questions for George in the chat too, and I can look at those. But if you don't mind, Ed, Ed Billinchon, I'm gonna surprise you for a second and take it over to you, because
shall we just say goodbye to our YouTube audience, and I'll turn the YouTube live off.
Do that. YouTube live folks, thank you so much.